Bismillah ar-Rahman ar-Rahim. Today we will start to discuss hematopoietic and lymphoid system disease. I want to first to tell you about the hematopoietic stem cell, and the stem cell that present in the bone marrow that responsible for differentiation to the any mature cell in the blood. At first, hematopoietic stem cells can be differentiated into common myeloid progenitor or common lymphoid progenitor. The common lymphoid progenitor that can give rise to either B lymphocyte or T lymphocyte or natural killer cell. And common myeloid progenitor, it is a cell that is responsible for differentiation to the other body cells like red blood cells, platelet, and other white blood cells like basophil, neutrophil, eosinophil, and monocyte. So the hematopoietic stem cell give two progenitor cell, lymphoid and myeloid. Lymphoid that can differentiate into B or T lymphocyte, natural killer cell, and common myeloid progenitor that can differentiate to the other blood cells except lymphocytes. At first, I want to talk about red blood cells. The first disorder in the red blood cells is the anemia. As you all know, that anemia, it is a decrease in the number of red blood cells or decrease in the normal amount of hemoglobin in the blood. And anemia usually diagnosed by decreased oxygen carrying capacity of hemoglobin. Symptoms of anemia, as you all know, it like paleness, coldness, yellowish of the sclera due to jaundice, decrease of hypotension, palpitation. It's the most common symptoms in the anemia. Pallor, weakness, enlarged hepatosplenomegaly. But the most important symptoms for anemia: pallor and palpitation, tachycardia, increase heart. And we can classify anemia into hemorrhagic anemia due to hemorrhagic blood loss, or hemolytic anemia, that means increase the rate of destruction of red blood cells or impaired red cell production. So we have three lines for anemia. Because anemia may be due to hemorrhage, I called it hemorrhagic anemia. Anemia may be due to increased the rate of destruction of red blood cells, I call this type hemolytic anemia. Third line of anemia, it may be due to decrease in the production of red blood cells, and this type include megaloblastic anemia, iron deficiency anemia, and aplastic anemia, and chronic renal cell failure. With renal cell failure, we have no production for erythropoietin, which is the important hormone for production of red blood cells. At first, we will talk about first type of anemia, which is the hemorrhagic anemia. Hemorrhagic anemia due to hemorrhage, and this hemorrhage may be occur due to trauma, surgery, gastrointestinal lesion like bleeding of the GIT, like esophageal varices, peptic ulcer, maybe bleeding due to gynecological disturbance, as in case of heavy menstruation, fibroid, also blood loss may be due to cancer, or maybe due to premature baby with infrequent taking of blood sample. Second line of anemia is a hemolytic anemia. As we know that hemolytic anemia means that we have increased destruction of red blood cells, and maybe we classified into inherited type or acquired type. So hemolytic anemia may be due to acquired cause or may be due to inherited or genetic cause. Red blood cells, as we all know from physiology, it have normal lifespan, which is about 120 days, about 4 months. Okay. When RBCs not function and it spare the normal lifespan, it will be removed by the peripheral blood by macrophage of spleen and liver. And this is the normal sequence occur when the red blood cells become non-function. It will be removed. Hemolysis means it is a premature destruction of normal and function RBCs. So hemolysis means it's a destruction of function RBCs. But what happened in normal, it is a destruction of non-function RBCs by macrophage. But in hemolytic anemia, the destruction occurs to the normal function mature RBCs. And this may be due to acquired cause, may be due to hereditary spherocytosis, thalassemia, sickle cell anemia, or glucose 6-phosphate dehydrogenase deficiency. All these types are types of hereditary hemolytic anemia, which occur due to hereditary error occur in the red blood cells, and we call this cause intracorpuscular causes. Acquired causes, I call these causes extracorpuscular. It is a causes from outside red blood cells. It can affect red blood cells and cause destruction to it. Like this cause may be like toxins, chemical injury, as in case of autoantibodies, in case of RH or ABO incompatibility blood transfusion. The third type of anemia, it is decreased production of red blood cells. Decreased production of red blood cells either occur due to deficiency of iron or deficiency of vitamin B12, or it may be occur at the level of the bone marrow as in case of aplastic anemia. At first, we will talk about iron deficiency anemia. Iron deficiency anemia, it is a type of anemia that can occur due to decreased intake of iron in diet, decreased demand of iron like in pregnant women and lactating women. Also, iron deficiency anemia can be occur due to loss of blood like in hemorrhage from ulcer or cancer of GIT, decrease in the absorption of iron as in case of achlorohydria, which means that we have decrease in the level of HCl, and as we all know that HCl is important for absorption of iron from GIT. Also, iron deficiency anemia can be occur due to heavy menstruation or due to parasitic infestation. Iron deficiency anemia, this type of anemia we call it hypochromic microcytic anemia, because in this type we have decrease in the size of red blood cells, so we call it microcytic. Also, we have decrease in the amount of hemoglobin in red blood cells, so we call it hypochromic type. Clinical feature of anemia is usually the patient of iron deficiency anemia usually manifested by atrophy of the tongue. We have also glossitis, inflammation of the tongue, dysphagia, which means difficulty in swallowing, and we have a syndrome in iron deficiency anemia with syndrome. We call this syndrome Blamar-Vinson syndrome. Blamar-Vinson syndrome is a syndrome occur in the iron deficiency anemia patient characterized by glossitis and marked dysphagia, which means decrease in the difficulty in the anemia. What are the causes of megaloblastic anemia? Megaloblastic anemia occur due to deficiency of folic acid that can occur in case of decreased intake of folic acid in diet or in case of some drug intake. The second cause of megaloblastic anemia is decrease of vitamin B12, deficiency of vitamin B12. That can also occur due to inadequate dietary intake, or maybe due to defect in the or lack of intrinsic factor, which is the important factor for the absorption of vitamin B12 from the stomach. We have in the megaloblastic anemia subtypes, we called it pernicious anemia. And usually pernicious anemia can result due to defect in the production of intrinsic factor. So we have in this type of anemia no production of intrinsic factor, so we have no absorption of vitamin B12, so this patient will suffer from megaloblastic anemia. Also, in pernicious anemia, we have another cause that may be occur due to antibodies that can block function of intrinsic factor. So, pernicious anemia, it is type of megaloblastic anemia that can be occur due to either decrease in the production or defect in the production of intrinsic factor, which is important for absorption of vitamin B12. Also, pernicious anemia can be occur due to presence of antibody that can block the function of intrinsic factor. Also, we have in this case no absorption of B12, and so the patient will suffer from megaloblastic anemia. The patient of megaloblastic anemia and pernicious anemia will be treated by vitamin B12 but with injection, because if we give this patient oral B12, it will not be absorbed due to this patient have defect in the intrinsic factor. So we must treat this patient with. Also, most of the cases of aplastic anemia may be occur due to aplastic anemia diagnosed by bone marrow biopsy. If I take bone marrow biopsy from normal patient, if I take bone marrow biopsy from a normal person, we will find that the normal bone marrow has about 30 to 70% of blood stem cells, and usually have low amount of fat cells, low fat cells. But normal bone marrow contain 30 to 70% stem cells. But in case of aplastic anemia, most of the blood cell gone and replaced by fat. So the bone marrow biopsy in case of aplastic anemia usually show many fat cells with decreased number of normal blood stem cell that can differentiate after that to the normal blood mature cells. Usually the patient of aplastic anemia treated oral manifestation of hematological disease like iron deficiency, folic deficiency or vitamin B12 deficiency. Usually the patient with this type of anemia suffered from angular stomatitis, inflammation at the angle of the mouth. Glossitis means inflammation of the tongue, and usually this patient will suffer from candidal fungal infection at the oral cavity. What is the meaning of polycythemia? Polycythemia means we have overproduction of red blood cells. Overproduction of red blood cells. And usually it can occur due to hypoxia. Hypoxia, like people that live in high altitude, and also people that suffer from lung disease of like emphysema. You know that high altitude places we have high decrease in the oxygen carrying capacity of oxygen tension in the blood in the high altitude place. Also emphysema produce hypoxia. So the bone marrow start to compensate this case of hypoxia, decrease oxygen tension in the blood, by increased production of red blood cells to compensate this case of hypoxia. And this lead to polycythemia. Also, polycythemia can be occur due to renal disease or tumor of the kidney that can lead to increased production of erythropoietin. And as you all know that erythropoietin increase production of red blood cells, and this will lead to also polycythemia. Polycythemia also can occur at the level of the bone marrow, and we call this condition primary polycythemia or polycythemia vera. Now we will talk about white blood cell disorder. White blood cells disorder, at first we have expression of leukopenia. Leukopenia means decreased white blood cells count, less than 3,000 per cubic millimeter. The causes of leukopenia may be due to hereditary factor, hereditary immunodeficiency, may be due to Cushing syndrome, due to stress. What is the meaning of neutropenia? Neutropenia means reduction in the number of granulocytes in blood. You know that we have two types of white blood cells, granulocyte and non-granulocyte. Granulocyte, which include B lymphocyte or T lymphocytes, and granulocyte white blood cells that include eosinophil, neutrophil, and basophils. Okay. Neutropenia means the reduction in the number of granulocytes in blood. So we have reduction in the number of eosinophil and basophil and neutrophil. Agranulocytosis means it is the severe form of neutropenia. So the term of agranulocytosis also means reduction in the number of granulocytes, but in the severe condition, severe reduction in their number. Lymphocytopenia means decrease in the number of the lymphocyte, and it is less common than neutropenia. The term of leukocytosis means increased amount of white blood cells in the blood, and usually leukocytosis increased number of white blood cells, but this cell characterized by normal white blood cells or healthy cells, because in leukemia also term of leukemia means increased number of white blood cells in blood, but in case of leukemia the white blood cells that increase not normal, but it is a tumorous cells, not normal cell. But leukocytosis, we have increased white blood cells count, and this white blood cells is healthy cells and normal cells. The causes of leukocytosis may be due to bacterial infection, usually in bacterial infection, and we have increase in the number of granulocytes like eosinophil, neutrophil, and basophil. Increased monocyte usually occur in case of TB, tuberculosis. Increased number of lymphocytes usually occur with viral infection or with the tumoral response. Sometimes with the tumor we have lymphocytic infiltrate. Increased eosinophilia, as we all know that eosinophils usually increase in case of allergic condition and parasitic infection. Now we will talk about bone marrow cancer. Bone marrow cancer, it is a cancer that starts in the bone marrow, and we have three different types of bone marrow cancer. The first type is leukemia. Leukemia usually in the white blood cells, but can also occur in other type of blood cells. We have in this type of leukemia increased number of white blood cells, but this time the white blood cells not normal. It is the abnormal cancerous cells. Not like in case of leukocytosis. Leukocytosis we have increased number of white blood cells, but normal function white blood cell. Multiple myeloma, it's the second bone marrow cancer, and it had rise from the plasma cell. Lymphoma, usually it begins in the lymph node, but can also arise in the bone marrow. Lymphoma means I have the malignant proliferation of lymphocyte. So it not affect lymph node only, mostly in the lymph node, but can affect any site contain lymphocytes. Any site contain lymphocyte like mucosa associated lymphoid tissue, CNS, any site that contain lymphocytes like bone marrow. Also bone marrow show lymphocyte, so the lymphoma can arise from the bone marrow. So lymphoma, lymphoma defined as malignant neoplasm of lymphocyte, mostly in the lymph node. We will talk now about leukemia. Leukemia means malignant proliferation of white blood cells or precursor of blood cells, which is hematopoietic stem cell. So leukemia means malignant proliferation of white blood cells or malignant proliferation of hematopoietic stem cell. Leukemia characterized by diffuse replacement of the bone marrow by neoplastic cell instead of normal cells. And we can classify leukemia into we have two classifications of leukemia. Classification according to cell line. We have two types of leukemia according to this classification: granulocyte or myelocyte leukemia or lymphocyte leukemia. If the leukemia arise from the granulocyte cell like eosinophil, neutrophil, basophil or monocyte, we call this type of leukemia myelocytic or granulocytic type. But if the leukemia arise from lymphocyte like B or T lymphocyte, we call this type lymphocytic leukemia. We have another classification of leukemia according to cell maturation. According to cell maturation, we can classify leukemia into acute or chronic. Acute leukemia that arise from immature cell. It arises from immature cell like lymphoblast or myeloblast. And it is a rapidly developing type and very aggressive with bad prognosis. The second type of leukemia according to cell maturation is chronic type. Chronic type leukemia that can affect mature cell like lymphocyte or myelocyte. And it is a slowly developing type of leukemia and less aggressive type with good prognosis. So leukemia, we can classify leukemia according to the cell from which the leukemia arises and according to cell maturation. So leukemia may be arise from mature cell. I call this condition chronic leukemia, and chronic leukemia may arise from mature lymphocyte. I call this condition chronic lymphocytic leukemia. But if chronic leukemia arises from myelocyte or granulocyte cell, I call this condition chronic myelocytic leukemia. But if leukemia arises from immature cell, it will be acute leukemia. And acute leukemia either may be acute lymphoblastic if it arises from immature lymphoblast cell, or maybe acute myeloblastic if it arises from immature myeloblastic cells. Leukemia, if it arises from it can be arise from hematopiotic stem cell, so it will affect all cell line. It can affect red blood cells, white blood cells, and platelet. And usually it affects bone marrow, blood, lymph node, liver, spleen. The cause of leukemia, most cases due to unknown cause, may be due to chromosomal defect, virus, chemical chemotherapy or therapy. The common symptoms of leukemia, usually the patient of leukemia will suffer from repeated infection due to decrease in the number of mature white blood cells. The patient of leukemia have excess white blood cells but cancerous cells, abnormal white blood cells, but this patient have absence of mature function white blood cells. So this patient will suffer from recurrent serious infection. Also, the patient of leukemia will suffer from ecchymosis, epistaxis, bleeding tendency due to thrombocytopenia, decreased platelet number. Also, the patient will suffer from fatigue, weakness due to anemia and decreased production of normal red blood cells. The patient of leukemia will suffer from also bone pain, tenderness due to bone marrow expansion by malignant or cancerous cells. Also, the patient will manifested by lymphadenopathy, enlarged lymph node, hepatosplenomegaly, enlarged liver and spleen due to also dissemination and infiltration of leukemic cells into lymph node and into liver and spleen. Sometimes the patient of leukemia will suffer from CNS manifestation like headache and vomiting due to also dissemination or infiltration of leukemic cells into central. Oral leukemic manifestation, this is important for dentistry student, include gingival swelling due to infiltration of gingiva by leukemic cells, bleeding tendency in the form of ecchymosis of the buccal mucosa or tongue due to decreased number of platelets, thrombocytopenia, gingival ulceration, pallor, mucosal pallor due to anemia, recurrent infection due to absence of normal or functional mature white blood cells. So the patient will suffer from repeated infection, mostly fungal infection like candida, and we maybe suffer from dental abscess. Cervical lymphadenopathy, enlarged cervical lymph node due to dissemination of leukemic cells into cervical lymph node. The patient of leukemia may suffer from laryngeal pain, osteolytic lesion in the mandible due to expansion of the bone marrow of the mandible, and infiltration of the subperiosteum by leukemic cells. This figure shows gingival hyperplasia in case of leukemia. Also, this figure shows ulcer, tongue ulcer, that also one of the manifestation of leukemia. And we have candidal infection at the tongue. Acute leukemia, defined by, as we said before, that acute leukemia means in presence of immature, that the cancer arise or malignant proliferation of immature cell. So in case of acute leukemia, we must have at least 20% of cells of a blast or immature cell in the bone marrow. So acute leukemia defined by presence of 20% or more of blast cell, immature white blood cells in the bone marrow. Characterized by decrease in the number of mature function cells and replacement of this mature cell by blast immature cancerous cell. Usually this patient treated by intense chemotherapy or bone marrow transplantation. It is aggressive condition with bad prognosis, characterized by clinically by, or the patient manifested by lymphadenopathy as general features of leukemia, hepatomegaly, splenomegaly, bone pain, repeated bleeding, and pallor, repeated infection. The first type of acute leukemia that arise from immature lymphoblast, we call it acute lymphoblastic leukemia. This type arises from immature lymphoblast. So it is the acute condition, because as we said before, the acute condition acute leukemia arises from immature cell. And this immature cell either lymphoblast or myeloblast. If it arises from lymphoblast, I call this condition acute lymphoblastic leukemia. As in this figure, the leukemia arises from the immature large lymphoblast, and usually it occurs in children. We have marked bone marrow replacement by malignant immature lymphoblast. It arises from B lymphocyte with bad prognosis, can be treated with transplantation. Chronic leukemia classified into chronic lymphocytic if it arises from mature lymphocyte, or chronic myelocytic if it arises from mature myelocytic. Chronic lymphocytic leukemia, it arises from mature lymphocyte, usually occur in old person. We have in this type overexpression of anti-apoptotic factor BCL2 that prevent apoptosis of cancerous lymphocyte or malignant lymphocyte with overexpression of these malignant cells. Usually this type not responded to chemotherapy, treated only by bone marrow transplantation. Second type of chronic leukemia is chronic myelocytic that arise from mature myelocytic or granulocytic cells. As you say, we have in this figure granulocytic cells arise from its leukemia like eosinophils. Okay. Usually this type associated with chromosomal translocation. We call this chromosomal translocation Philadelphia chromosome, because in this type we have translocation between chromosome 9 to chromosome 22. This type has bad prognosis and treated only by bone marrow transplantation. So leukemia, it may be either acute or chronic. Acute arise from immature cell. Immature cell either in the form of acute lymphoblastic leukemia or acute myeloblastic leukemia. But chronic leukemia arise from mature cell, and also it may be chronic myelocytic if it arises from mature myelocytic cell, or chronic lymphocytic if it arises from mature lymphocyte cells. Now we will talk about lymph node. You know that the normal histology of lymph node, the normal lymph node formed of lymphoid follicle formed mainly of B lymphocytes, and between the follicle we have paracortical areas that formed mainly of T lymphocytes. As this figure of normal histology of lymph node, we have capsule and we have lymphoid follicle formed mainly of B lymphocyte. In between follicle we have paracortical area that formed mainly of T. We have in the lymph node disorders two variants. Lymph node disorders either in the form of inflammation, we call inflammation of lymph node lymphadenitis, or in the form of neoplastic condition lymphoma. So lymph node disorder may be non-neoplastic or neoplastic. Non-neoplastic in the form of inflammation of the lymph node, which is lymphadenitis. Or have other disorder of lymph node, which is malignant lymphoma, which means malignant proliferation of lymphocyte. At first, we will talk about reactive lymphadenitis. Reactive lymphadenitis means inflammation of the lymph node. It is a non-neoplastic reaction to presence of infection, either viral infection, bacterial infection, okay, or other type of infection, or maybe due to reaction to necrosis or reaction of tumor. Sometimes in case of tumor, we have a lymphocytic infiltrate associated with the tumor. Okay, but the cause of lymphadenitis, most common cause is due to infection. So lymphadenitis means inflammation of lymph node that occur due to infection. Usually this lymphadenitis, it can either affect the lymphoid follicle, we call this type follicular type, can affecting sinusoid of lymph node, or it can take a specific pattern in the form of granuloma or inflammation. Reactive lymphadenitis usually characterized by presence of 5 types. We have 5 types of 5 patterns of benign lymphadenopathy. The first type is acute lymphadenitis that can occur in any area drained infection, occur due to bacterial infection in the area drained by lymph node, like acute tonsillitis. Usually the child that suffer from acute tonsillitis usually have cervical lymphadenitis due to drained infection from the infectious area like tonsil into the cervical lymph node. Usually microscopic examination of the lymph node in this condition show sinus dilatation with accumulation of neutrophil. You know that the neutrophil is the characteristic cell for acute lymphadenitis. Second type of reactive lymphadenitis is follicular hyperplasia. Second type of lymphadenitis is follicular hyperplasia, and usually it affects the lymphoid follicle, characterized by presence of enlarged lymphoid follicle. It occurs in the autoimmune disease, some infectious disease like toxoplasmosis, syphilis, okay, and usually in this type of lymphadenitis, under microscope we have increase in the size and number of the lymphoid follicle that characterized by presence of B cell. Third type is the paracortical hyperplasia. Usually it characterized by extension of the paracortical area that characterized by presence of T cell. So we have enlarged and extension of the paracortical region, and usually it occurs in case of viral infection, most like Epstein-Barr virus infection that can cause non-neoplastic disease. We call this disease infectious mononucleosis. So infectious mononucleosis, it is a non-neoplastic disease that can caused by Epstein-Barr virus. So viral infection usually characterized by paracortical hyper. Sinus hyperplasia, it usually occur in case of lymph nodes that draining malignancy or inflammatory lesion. And we have in this condition expansion of the histiocyte in the expansion and infiltration of the sinus by histiocyte. So this type of lymphadenitis characterized by presence of excess number of histiocyte in the sinus of lymph node. Granulomatous lymphadenitis, as you know before in the chapter of inflammation, that granuloma, it is a chronic specific type of inflammation, and usually it's seen in case of granulomatous disease like tuberculosis and sarcoidosis. Under microscope we have characteristic formation of granuloma in the lymph node. Now we will talk about neoplastic condition of the lymphocyte, which is the lymphoma. As we said before, that disorder of lymph node may be either non-neoplastic in the form of lymphadenitis, inflammation of lymph node, or in the form of the other disorder of lymph node is the lymphoma. And lymphoma means malignant neoplasm, malignant tumor, or malignant proliferation of lymphocyte. So lymphoma, it is the malignant tumor derived from lymphocyte. Usually occurs in the lymph node, but not always. It can occur in other organ or other soft tissue that contain lymphocyte. So any organ or any site contain lymphocyte, lymphoma can arise from it. So lymphoma usually, but not always in lymph node. We have in this figure characteristic enlarged lymph node due to presence of lymphoma. Clinical features of lymphoma include night fever, night sweat, loss of weight, loss of appetite, as a general features of any malignant tumor. Types and cells of origin of lymphoma. Lymphoma classified in two large types. First type is Hodgkin lymphoma. The second type is non-Hodgkin lymphoma. The cell of origin differ from both type. The Hodgkin lymphoma, usually it's a specific type of cancer that derived from B lymphocyte only. So Hodgkin lymphoma arises only from B lymphocyte. Non-Hodgkin lymphoma, it arises from B or T lymphocyte. But B lymphocyte is the most common. B lymphocyte lymphoma account for about 85% of non-Hodgkin lymphoma. Only 15% of non-Hodgkin arise from T lymphocyte. So the Hodgkin lymphoma, all cases of Hodgkin lymphoma arise from B lymphocyte. Non-Hodgkin lymphoma, 85% arise from B lymphocyte. Only 15% arise from the T lymphocyte. As in this figure, which is bilobed, mirror bilobed nucleus with prominent nuclei, which we called it mirror image sometimes. But we have also other variant of red Sternberg cells, like lymphohistiocytic or popcorn cell, like popcorn, like in this cell. This cell, it is a variant of RS, but not classic form. This form or this variant, we called it popcorn or lymphohistiocytic cell. We have other variant like lacunar cells, like this, with formation of lacuna around the nucleus. We have also polymorphic red cells with polymorphic nuclei. We have also mononuclear Hodgkin cell characterized by presence of one nucleus. These four variants of red cells, these also red blood cells, but not in the classic form. But these cells also can present in case of Hodgkin lymphoma and help in the diagnosis of Hodgkin lymphoma. Hodgkin lymphoma characterized by presence of inflammatory background, in the form of non-neoplastic or normal lymphocyte, histiocyte, fibroblast, and marked eosinophils. Okay, with presence few number of red Sternberg or RS cell, which is important and characteristic for diagnosis of RS. So the background of Hodgkin lymphoma formed of inflammatory normal cells, and we have few RS cell, red malignant cell, and the only malignant cell in case of Hodgkin, it is the red Sternberg cell. The other cell that present in the background of Hodgkin are inflammatory non-neoplastic normal cells. So to make diagnosis of Hodgkin lymphoma, we must have two features or two findings. At first, the presence of red Sternberg cells, either in classic form like this. We have in this figure classic RS with bilobed nucleus and prominent nuclei. Okay, so RS is important for and it's essential for diagnosis of Hodgkin lymphoma. And other finding is presence of inflammatory background. So Hodgkin lymphoma require two features microscopically to be diagnosed. At first, RS cell, and the second feature is inflammatory background. This type, which is a nodular lymphocytic predominance in category alone, due to this type, because this type don't contain classic RS. Because lymphocytic predominant Hodgkin lymphoma not contain classic RH, so this type is put alone in category. Okay, so nodular lymphocytic predominant Hodgkin lymphoma, WHO put it in a separate category, not under classic Hodgkin lymphoma, because this type, nodular lymphocytic predominance, don't contain classic RS, classic red Sternberg cell. So this type put in the separate category, not put under classic Hodgkin lymphoma. But all variant of classic Hodgkin lymphoma must be contain classic RS. Nodular lymphocytic predominant, which is the separate entity or separate type in the WHO classification, characterized by presence of popcorn or lymphohistiocytic cells, but there is no or very rare classic RS. So this type put in the separate entity in the WHO classification. We have no classic RS, but we have instead as other variant, which is popcorn, because we must have any variant of RS cell to diagnose Hodgkin lymphoma. But this type not contain classic, but contain other variant, which is popcorn or lymphohistiocytic cell, which is essential for diagnosis of Hodgkin lymphoma. And as background of case characterized by inflammatory infiltrate. Classic Hodgkin lymphoma characterized by presence of classic red cells, red Sternberg cells, that characterized by looped nucleus with prominent nuclei. Other variant also can be present, but we must have variant of classic. And the classic RS usually has characteristic stain that is a very characteristic for it. Classic RS usually characterized by positivity for stain CD15 or CD30. Also, classic RS negative for B cell marker like CD19, CD20, and also negative for T cell stain or T cell marker like CD3 or CD5. Also, it is negative for common leukocytic common antigen CD45, which is a characteristic for normal lymphocyte. So classic RS have characteristic immune stain, which is a positivity only for CD15 or CD30. So sometimes if under microscope I have large cell like RS, but I suspect this cell is RS or not, I will stain this case with CD15 or CD13, 15 or CD15 or CD30. If the case is positive, so I am sure that this cell is RS and I will diagnose Hodgkin lymphoma. But if the stain is negative for CD15 and CD30, so this cell not RS, and so there is no diagnosis of Hodgkin lymphoma. First variant of classic Hodgkin lymphoma is nodular sclerosis. Nodular sclerosis is the most common type of classic Hodgkin lymphoma, characterized by presence of two features: presence of classic cells and presence of lacunar cell. Lacunar cell, it is a characteristic variant that present in nodular sclerosis, that characterized by presence of lacuna around the nucleus of the RS cell. Also, this variant characterized by presence of nodules. From its name, nodular sclerosis. Nodular means I have in the microscopic feature of this type, we have formation of nodule. These nodules separated by collagen band. So we have collagen band divided the lymphoid tissue into the nodule. So we call this type nodular sclerosis. So nodular sclerosis type characterized by presence of collagen band and lymphoid nodule, and also presence of lacunar cell. Lymphocytic rich classic Hodgkin lymphoma, from its name, characterized by presence of large number of reactive or inflammatory normal lymphocyte and small number of red Sternberg cells, RS cell. So this type has good prognosis. Due to it is a lymphocytic rich, characterized by presence of large number of inflammatory background or inflammatory lymphocyte, which is the normal cell, and this type has small number of RS cell, which is the malignant cell. So this type is a good prognosis. We have in this figure classic RS. We have also in this figure mononuclear Hodgkin cell like this, and we have inflammatory background formed of normal reactive lymphocyte, which is predominant than the malignant RS cell. So this condition has good prognosis. Other variant is lymphocytic depleted type, which is characterized by presence of a small number of reactive normal lymphocyte and a large number of polymorphic cells. Large number of RS cell, usually in the form of polymorphic variant like this. And this type has bad prognosis due to presence of large number of neoplastic RS. Last variant of classic Hodgkin lymphoma, which is the mixed cellularity, characterized by heterogeneous cellular infiltrate between RS and inflammatory background cells. Staging of lymphoma. Staging of Hodgkin lymphoma. We have a stage of Hodgkin lymphoma called it an Alport staging of lymphoma. We have 4 stages in lymphoma, in Hodgkin lymphoma, from stage 1 to stage 4, and each stage can be subdivided into A or B. A if the patient has no symptoms, asymptomatic, but if the patient has symptoms like night fever, night sweat, loss of weight, loss of appetite, we subdivide the stage into B. So each stage, like stage 1 may be stage A if the patient has no symptoms, or stage 1B if the patient has symptoms. Also stage 2 may be stage 2A or B, stage 3 also A or B, stage 4 also A or B, according to presence or absence of symptoms. Stage 1 means we have involvement of single lymph node or involvement of extranodal site. Stage 2 means we have 2 or more lymph node affected, but at the same side of the diaphragm. Either the lymph node affected or lymph node above diaphragm, subdiaphragmatic, or below diaphragm, infradiaphragmatic. Or stage 2 also may be due to limited adjacent affection of extranodal site. Stage 3 means that I have lymph node affection on both sides of diaphragm, above diaphragm and below diaphragm, and we have also presence or absence of splenic involvement or extranodal involvement in multiple sites. Stage 4 means we have multiple dissemination and presence of multiple lymphoma in the multiple lymph node or and extra. So we have in this figure involvement of one lymph node, stage 1. Stage 2 we have involvement of 2 lymph nodes, but the 2 lymph nodes affected above diaphragm, subdiaphragmatic, so it's stage 2. In this figure we have affection in the lymph node above, and we have also affection of the spleen and lymph node below the diaphragm, stage 3. Stage 4 we have multiple dissemination, lymph node, splenic involvement, and liver involvement. Now we will talk about second type of lymphoma, which is non-Hodgkin lymphoma. Non-Hodgkin lymphoma, it is a malignant proliferation of either B or T lymphocyte. B non-Hodgkin lymphoma account for about 85%, as we said before. T-cell non-Hodgkin lymphoma account for about only 15% of cases of non-Hodgkin lymphoma. We have also like Hodgkin affection of nodal or extranodal site. It may be affecting localized lymph node or affecting generalized lymphadenopathy. We have a large lymph node in whole the body. Increase with age. The risk factor of non-Hodgkin lymphoma may be due to AIDS, autoimmune disease, immunosuppressive drugs, virus infection. The most common virus responsible for non-Hodgkin lymphoma is EB virus, Epstein-Barr virus, or human T lymphotropic virus. Other cause of non-Hodgkin lymphoma due to some bacteria like H. pylori, Helicobacter pylori, which is a bacteria characteristic for gastric lymphoma, can cause gastric lymphoma. Other cause like chemical exposure, fertilizer, and other. Viral infection is important in non-Hodgkin lymphoma. EB virus is very important. Epstein-Barr virus can cause non-neoplastic condition in the form of only inflammatory condition in the form of infectious mononucleosis, and can cause neoplastic affection of the lymph node in the form of non-Hodgkin lymphoma. So EB virus can cause non-neoplastic condition which is infectious mononucleosis, or can cause neoplastic condition in the form of non-Hodgkin lymphoma. Because EB virus can cause malignant tumor or lymphoma, we call this virus oncogenic. So EB virus, it is one of the oncogenic virus that has the ability to produce neoplastic or malignant tumor. Classification of non-Hodgkin lymphoma. We can classify Hodgkin lymphoma according to growth rate into indolent, very slowly growing, or aggressive, fast growing, rapidly growing lymphoma. We can classify also non-Hodgkin lymphoma according to cell type into T cell and B cell or natural killer cell. WHO classification of non-Hodgkin. WHO classified non-Hodgkin lymphoma into low-grade type like small lymphocytic lymphoma, follicular lymphoma, intermediate grade like diffuse large cell B cell lymphoma, high grade type like lymphoblastic lymphoma or Burkitt's lymphoma. And you must know the subtypes for each grade. So follicular lymphoma, a small lymphocytic, it's a type of low grade lymphoma. Diffuse large B cell, type of intermediate grade lymphoma. Lymphoblastic Burkitt's, type of high grade lymphoma. Small lymphocytic lymphoma, which it is a variant of low-grade lymphoma. We have loss of nodal architecture, no lymphoid follicle, normal lymphoid follicle pattern not present, and replacement of nodal architecture by presence of a small lymphocyte. Usually it arises from B lymphocyte, which is a positive for B cell marker or B cell immunostain like CD19, 20, and 23. Follicular lymphoma characterized by presence of nodular or follicular pattern, and usually it has good prognosis, but it can progress to diffuse type. This type has better prognosis than diffuse, and we have in this type also chromosomal translocation between chromosome 14 and 18. And we have also overexpression of anti-apoptotic gene BCL2. Follicular lymphoma can be subdivided into a small cell type or large cell type or mixed cell type that contains small cell and large. Diffuse large cell, we have replacement of nodal architecture and infiltration by neoplastic large lymphoid cell. We have capsular and extracapsular invasion. Bad prognosis. Then lymphoma can be progressed to diffuse. Burkitt's lymphoma, it's a type of the high-grade lymphoma. It's a special type of lymphoma that is endemic in some part, in some area and some part of Africa, and sporadic in other area. Endemic in Africa, but it's a sporadic in other area like America. Usually affecting head and neck, common in children and young adults, caused by infection with the EB virus, Epstein-Barr virus. We have two types of Burkitt's lymphoma, African type or American type. In the African type, it usually affecting maxilla or mandible. In American type, usually the tumor affecting the abdomen. Burkitt's lymphoma characterized histologically by very characteristic feature. Usually, it's histologically formed of presence of sheets of small to medium-sized lymphocyte, small lymphocyte with round nuclei, basophilic cytoplasm, basophilic nucleoli. So we have infiltration of lymph node by small lymphocyte with bluish cytoplasm and bluish prominent nuclei. These cells usually laden with lipid droplet. Contain lipid droplet. We have also at Burkitt's lymphoma, we have tangible body macrophage that engulf the lipid droplet, so it appears as white. Because it engulf the lipid droplet, it appears as a white star, a white appearance. So macrophage appear with vacuolated cytoplasm, so it appears like a white star. But the malignant cells, malignant small bluish cells, appear as a sky. So we describe this microscopic feature of Burkitt's lymphoma by star sky appearance. Star sky appearance means that I have the sky that's formed by the malignant bluish small lymphocytes and star in the sky that represented by the macrophage that engulf lipid droplet, so it appears as a white star against the bluish sky. So star sky appearance is a very characteristic features, characteristic appearance for Burkitt's. Last item in our lecture today, we will talk about differential diagnosis of lymphadenopathy. Lymphadenopathy means enlargement of lymph node. Enlarged lymph node may be either due to infection. The infection may be due to virus. Most important virus like EB virus, Epstein-Barr virus, may be bacteria, may be due to fungal infection or parasitic infection. Enlarged lymph node may be also due to malignancy like Hodgkin, non-Hodgkin lymphoma or leukemia. May be due to metastatic carcinoma from any primary site, can metastasize to the lymph node. Maybe large lymph node also due to autoimmune disorder like systemic lupus, maybe due to drug reaction or lipid storage disease. Now we will finish. We finish our lecture today. Thank you for good listening and your attention. Good luck for all of you. Thank you.